formation of this new treatment, TILS therapy. So looking at all these cells and looking out at the different types of cells, even the vascular endothelial cells, that is the reason why your VPGF therapy, the benefits have not been lacked. So this gives us a lot of scenario and a picture as molecular pathologists in how the tumor is going to behave. So this is what this was an observed molecular pathologist.
Can I ask you to just stop here for a second? Okay, so here we have somebody with a stage 4 lung cancer. I think I'll just say it's a stage 4 lung cancer. I'll start with you, sir. ALK-IHC positive. Good enough for you to start some treatment, or you would want to do an NGS, you want to do a FISH or some confirming? So
usually we send to 20 panel. We don't do IHC.
Okay.
Last 3 years I am always sent for 20 panel. Otherwise initially I put IHC.
Okay.
Then I will send for a confirmation.
And why is it so?
Because in a few cases we have conflict in the past.
Okay, fantastic. Sir, IHC is good enough, or you would want to wait for the NGS report? NGS report. You will not want to act on this.
It's a good enough, but
It depends on the symptoms.
Depends on symptoms. The patient wants to start the treatment yesterday. They will look at that, no? Because when everybody will say, let us start the treatment, something has come positive. And sir, if IHC is positive, NGS is negative, what will you do?
Can be negative sometimes.
Yeah, so what will you do? Will you start?
start treatment.
You can start. And Dr. Anita?
Yeah, IHC positive, lab is authenticated, pathologist is okay, I am okay.
What is the definition of pathologist is okay?
She's confident. She's confident. It's a positive. I am positive. IHC is good enough to start treatment at any point of time.
IHC is
No, you don't do. Actually, the IHC and report will come much before
Yes.
you are getting.
So I'm coming to that.
3 days you are there.
Yeah, 2. Because sometimes they come before they have the PDF report. Yes.
Yeah, right.
Disclaimer is that we used to do IHC for ACT, now we are not doing
Okay.
it, we are dependent on 12-gene panel.
Okay.
Here there is a catch. The catch is there are a lot of lymphocyte infiltration. I'm asking you whether the ALK is positive on the lymphocyte
No,
or
it's
the
on the tumor
tumor
cells.
cells.
That's what I told pathologist is good.
It's on the tumor cells.
Pathologist is okay.
You know, this can be an ALK positive ALCL also.
No, it's a ALK positive NSCLC. Tumor cells. TDA1 positive.
But I doubt my pathologist.
You doubt your pathologist?
I'll tell you why. Because,
If I is not center to center.
No, I'll tell you why. Because
Your pathologist is not here, no?
no. Even if pathologists are there, I don't mind. I'll tell you why. Because
That is why I love coming to Kerala.
no. I'll tell you why. Because most of the pathologists are trained in a place where there is no IHC. Including many of the government medical colleges are not doing IHC till recently, and they learn IHC after they pass out the MD, they go out and then learn. This is the scenario until very recently in Kerala.
I don't know when
it's true.
Our pathologists are not trained in morphology. They are trained only in IHC. They will not go and they will not go and squamous cell also before doing the P40 actually.
I'll tell you. And if I send one IHC report to 3 labs, I'll get
Different.
three reports.
Wow, fantastic. Three
This
different
is
reports.
3 different reports.
Yes.
And there are only very few good pathologists in Kerala who are trained in doing a good IHC, and they are going to give a proper report.
More than
And this is a fact.
Fair. So you don't
This is
trust
a fact.
IHC.
And if we need to do an IHC, it has to be in a reputed lab where they have a history of doing IHC for a long time. They have most of the IHC markets, and they can, mostly in an academic center or in a large center where they treat where it's attached to an oncology facility. I trust their IHC, otherwise I will not trust their IHC.
Okay, let's say it has gone to the places where you send and trust. Then what will you do?
Suppose
Then probably that
Suppose
this
it's coming from
Authenticated.
Amrita.
PMH. I do believe that.
RGCI.
Yes, we'll believe you.
But he could have said no also. I would have told me
We'll believe you but I'll not, if the patient is stable, I'll not be, I'll not hesitate to wait till the NGS.
Fantastic, ma'am. What will you do? Fantastic.
And the radiation oncologist
Doesn't make a difference. Doesn't make a
both
difference.
are the same center.
You trust a radiation oncologist? no?
Yes, at least you trust your radiation oncologist.
I mean, that is normally, we trust our pathologist, the radiation and surgical oncologist is something which we don't trust.
We trust my pathologist. In our hospital, we trust our pathologist. But we will not trust all pathologists. No.
What I was trying to say is in our hospital we actually
They
We have
IHC for very
IHC
few
for-
things. So then only TTF1 and T40 is done.
Fantastic.
And then we send for more.
resource.
Recently I had an experience in the cancer. Few days we are getting more HRP positive. Then we asked what the problem. Then went back to again.
The red HRC.
Then changed the platform, there's a change in the state.
That is why everybody was getting more
Then we went for fish for all this.
Training is required for the
Yeah, again,
pathologist,
also bring me some
and proper space need to be provided.
Then we can have a planning program. Like a program.
Okay. So,
Looking at this pathology, what do you think would be a probable possible diagnosis?
And
Just
it also
looking at this-
depends upon whether you are doing it automated on an automated machine, manual
Yes.
machine,
Yes, we should
and
train-
everything is important.
correct. So for
And another question of yours with the lymphocyte infiltrate will tell us also whether this microenvironment is immune responsive or immune resistant environment. So that's what I was also thinking, lymphocyte infiltrate against
Yes.
points you to your indication to more.
And this type of morphology also lets me know that it's not only ALK, red can also be positive, MET can also be positive because the morphology tells you a lot about different positivity on the body. And this is known as a molecular morphology or morphogenomics, which is coming up very recently.
okay, before this, yes, please.
So in the pathology report, right now we are discussing that. So one of the another interesting thing what you can observe is, if you are observing the mesenchymal cells, epithelial cells also there, mesenchymal cells also there, you can most likely you can see MET, especially in the lung actually. So the expansion for the MET is mesenchymal epithelial transition is the short form of MET. So whenever you are seeing the MET example skipping or MET amplification, always in the histopathology report you will see the epithelial cell mesenchymal transition. So what is the point I am making is always the molecular pathologist or the histopathologist, whatever they are observing the cells, you can connect the dots with the molecular. So that these are small clues. Whenever you are coming to your possibly 90%, many cases we have seen that immunotherapy is not responding. Right? So these are the clues we can confidently learn whether the immunotherapy is going to work or not.
Correct. So just a point from a clinical perspective, let's say it's from a good lab, the pathologist that we trust and everyone, I'll say about us. What we do in our lab is, let's say a patient comes today, we get a biopsy done today, we send histopathology and there is a code called as lung with reflex up to 4 IHC markers plus PDL1. Because that's a test which is basically all IHC based. In that they will do 4 markers till there, they will do for everyone. So they do a P40, TTF1 and they also do a PDL1. So in 2 days time the report will come. Then we send them for molecular testing. In molecular testing we send for a single gene EGFR testing. We do send for ALK by IHC and then reflexively we send everybody for NGS. So that has given us a chance to do concordance. So now, if you have 100 patients who are positive by if you have 50 patients who are positive by a single gene PCR and you subsequently did an NGS for them, all 50 of them are positive, but in addition you will get 10 more EGFR positive because the PCR probes did not happen. So single gene EGFR will underestimate. Dr. George has gone thrice in this discussion outside to operate, I guess. Too much willpower. I agree with that. So if it's only a single gene EGFR, your NGS will definitely add 10% extra and give a paper on that. But if it's an ALK, if you have ALK positive by IHC, there is not even a single case in the last 500 patients of NGS that we have done, which IHC has missed and NGS has picked up. However, there are other variants. There are variants like variant 5 and other things which are not in your NGS. So again, if it's a hotspot NGS panel, if you don't have that fusion to look for, you will not get it. So those rare fusions and all, there are 3% of people which will be positive on IHC and negative on NGS. Second, IHC is not that labor intensive. IHC, this is the impression that I was given. Any Tom, Dick and Harry can do IHC reporting. In art, this is what my people told me. Anything on brown is IHC is positive. So the knowledge they give you, even you can see. I said, okay, if I can see, anybody can see. So that is what, and IHC report will come in 2 days time. So because we have 8% chance of EGFR, 25% chance, 8% of ALK and 25% of EGFR, we do an ALK by IHC, confirm by NGS, but we do start the patient on the ALK TKIs if the IHC is positive. Again, ALK IHC should be done on a good platform, Ventana. The antibody use has to be D5FA. No shortcuts in that. And then it's okay. Is that right, Dr.
Yes, absolutely. I think this is the right rules. This is whatever is validated and it's properly done by NABL and CAP accreditation with the laboratory standards. I think there should be a very good. So I think let's move to the next case, this one. And as usual, the patient had an ALK fusion. Plus, it had a very important mutation. It was L196N. Mutation was present, that's why the patient was progressing. He was not responding to the ALK inhibitor. And this is the different mutations, the incidence of different mutations which can come after the alectinib, aticaprem. And then these are the different sensitivity of different mutations with the different fusions. I think we are done. The patient was progressing because of the additional mutation, and I think it was put on broadband, and this is the next case. So this case is a very interesting. I'll just make it very short. The patient has an ALK positive mutation, which was diagnosed on IHC, and he was started on alectinib and broadband. The patient did not respond. He had a PD-L1 of 98%. So I think the therapy was started, which went on well for a year's time. And then afterwards, she again started progressing. And that was the time a bigger panel was done. And then in the bigger panel, we had a combination of ALK and TPP, which would be one possible reason for mutation resistance. And then also we had an HRD of 50%. This was a very rare finding in lung cancer. The loss of heterozygosity of 20%. So because of the HRD presence, we put the patient on Pembro. The patient is already in Pembro, so we added Ullas, and now the patient is doing very well, and there is a trial going on also. So this was a very interesting finding, so I thought you could share. And then the third case is again a 78-year-old male with the family history of prostate cancer, PET-CT as usual, IHC. I will not get into the detail of it. So what I wanted to tell you was the different morphologies have different patterns, which again we can miss. So this patient has a PET exon skipping mutation with MDM2 amplification. The patient was put on treatment. He did fine after that. Then the next case is again a non-small cell lung cancer, and the ALK was positive, and also the patient had a ERK2 mutation. Along with that, he had an APM phase shift mutation plus one 52% BAF R3047, which was a germline mutation. So this was just a way to tell that the germline mutation sometimes can be picked up and confirmed by germline testing. So because of the ERK2 mutation, the patient was put on this combination treatment, and the patient is doing well. And then one last case in which the adenocarcinoma, he was initially diagnosed with adenocarcinoma in the ascena pattern, and the patient was ALK positive, L858R, and the patient was under chemo and diclofenac. And after the patient was diclofenac, he developed a severe reaction, and then later he came up again with a metastasis to prostate, and we then did a bigger panel. So this patient was actually transformed into small cell carcinoma. So that was the time we did the NGS testing. So So in the NGS we had EGFR, TP53 and FBXW7. So the RB1 mutation loss was missing in this particular case. So what I wanted to highlight was that there are different types: small cell, large cell, SCC-like large cell. Then we have NSCLC like large cell neuroendocrine cancer, which will not have the co-mutation of RB1 and P53 or even these mutations. So you might have some mutations which is not related to small cell carcinoma. So I just wanted to highlight this point. And this patient had a L5858R as at a VAP of around 84%. So probably we were dealing with a germline mutation. The patient expired and we could not do a germline testing. So I think it's time to start looking for germline mutations also in the lung cancers. So this case I wanted to highlight this particular case. And thank you for
I think any comments from any final comments? I'll start out on the
How to choose the, I would like to get the maximum panel to get a panel to explain on the patient. How to choose my panel? Whether it only is okay or extended panel is okay. Which is the panel?
How to choose the right panel?
In present scenario, because you are evolving. Treatment is evolving, things are evolving.
See, we are trying to develop one of the good systems in India, and I can just talk about my experience. So, initial screening, yes, you can go for a smaller panel because not every patient can afford. And
My patient affording it, yeah, but everything is there.
so I personally, if you ask me my personal belief, before starting treatment, who goes solid and liquid, so that you don't
Solid.
solid and liquid biopsies, do both, so that you don't miss on anything, you don't miss on the heterogeneity, and then after the treatment, keep following on liquid biopsy. This is my personal belief.
Okay, so I, as usual, don't agree with this Mumbai thing. I think what you wanted to ask was how to select a panel. I think the first thing is small, medium, large will come later. I don't think CGP for everyone in Indian scenario is the right choice. I think it will be too much wastage of money. It's almost like saying, giving a Pfizer COVID vaccine to everyone in India. It is not possible. So talk to a lab. Talk to the scientist, talk to the pathologist involved. Talk to them regarding what exactly is your requirement. Listen, and also ask them if they will give you the raw data. And the most important is they are able to give you the VSQ file or the raw data. I mean, by and large, things are okay. See if they are CAP accredited, there is NAD accredited or not, and then go ahead with that. So, and also, you can't have the same panel in ovarian cancer versus the same panel in lung cancer versus the same panel in this. So, we as medical oncologists need to have a basic knowledge about what we exactly want, and then go ahead with it. Most of the commercial labs have a thing, but if we start looking at the final points, I don't know what was the lighting, why have you not mentioned, what is the depth of the coverage, it's only 5,000. So one more thing is, if you are looking for a liquid biopsy, have a 30,000 X coverage. If you are looking for a tissue biopsy, at least a 5,000 X coverage is very, very important. So look at these small points where they are included in the final report or not, and then see further. But I think again, patronize one lab, talk to the people, get convinced, and then go ahead with that.
See, this is an exercise which you have to do the lab you want to trust. See, there is a figure which they give. The particular sample had so much of NPG data generated. The depth for this panel was this patient was this much and coverage was this much. What we do in our reporting is, if I call a variant with EGFR or KRAS, I will mention on this much depth this variant was called. Because that will give you a more confident approach to the clinician and to yourself that you are doing the same thing. So what we do, sometimes we don't get coverage or homogeneously in all the genes. So there will be some portions which are not covered adequately. So your hotspot is there. And if you say overall, you have 98% coverage, you are actually surveying. So if the lab is reporting, just ask them, this variant you have called at what depth. I don't want the whole gene, I don't want the whole patient depth, I want that.
Also, one more point. Sometimes, and this is what I found foundation medicine guilty of. You look at all the reports that Madam showed. They just report the main mutations over there. They will not report the BAF. BAF will come later. It will come on page number 7, 8, 9, 10. Now an EGFR mutation covering at a VAF of 3.8% may not be very relevant to me. So VAF of 5%. I think, sir, molecular tumor board is necessary. We have to realize whether we hate it or whether we like it. We have to be friends with a molecular pathologist. We need to understand that. We both need each other. That is very, very important actually. Any points? Yes, sir, you had a point.
Sir, the pathologist.
Sir, I am Ullas and you are sir. Okay, sir, please go ahead.
Pathologist asks for ISC for eye confirmation.
Yes.
How to proceed?
For all confirm.
Eye confirmation.
No, sir. No. Tell them the pathologist, NCCN guidelines. If your ISC is positive by D5F3 on the Batra clone, you do not require. Sir, pathologists do not decide. It is in my hospital. As a medical girl, I decide. I am the one to take treatment, sir.
I think the guidelines decide.
Guidelines decide.
No, in the report the pathologist mentions that.
Let them write. You write over there in the
So,
NCCN guidelines.
but it has to be a good lab.
Yeah.
It has to be an order.